So in the healthcare industry, we are constantly reminded that if it is not in our documentation, it didn't happen. And I'm wanting to challenge that thought process and actually suggest that the things that we do not put in our notes might just matter the most. So this is Uncharted. We have Lee Lipscomb here. He's been a PTA, a physical therapist assistant, for quite a while now, a little bit longer than me. So I'm going to have you just kind of tell me when you got started, how you got started, and then we'll kind of flow from there.
So I did this in the Navy first. That's where I started. So in the Navy, for me, it was OJT, so like a tech, working in there, doing that along with other duties. You usually have a rotation in the Navy for corpsmen do for different fields in the hospital, and then wherever you go, Marine Corps, whatever you do later on, different assignments. So I started in '89 doing this. My mom had multiple sclerosis, the non-remitting. She died when she was 40, I was 10. So that probably played a part. It wasn't a real conscious thought of doing, I got to do it because she had MS. It was more probably just something that happened. But it was a good place to start because now you're starting to, kind of give back and see things. And so that's where it started. Navy, got out, went to Florida State got a degree in something a little bit different, and couldn't find a job, so I applied to PTA school. Of course, PTA picked me up quick, and I went. And that's, went through school for that, got out and started working.
That's cool. And you've worked multiple settings?
Yeah.
Or where was your start? Where did you, when you got out of school, what did you go into first?
I worked at a rehab center, a subacute rehab, Health South at the time. They're called Encompass now. Worked there in Panama City, Florida for several years. Great place to learn. You saw everything. Strokes, ortho, whatever it was. A lot of strokes.
Yeah.
But that was a great place to learn. Subacute, I've worked that. I've worked acute care, managed outpatient, home health, every setting you can do.
Yeah. What would you say is your favorite? Do you have a favorite, or do you have a home?
Yeah, well, home health is my favorite.
Yeah.
Now, the personal part of home health is not so much my favorite because you're not around friends.
Yeah.
You're around patients, which they become your friends. When you work in subacute or outpatient, you get to play around with your colleagues.
Yeah.
Have a good time and get to know them.
So kind of like a coworker dynamic along with it, not just the patient.
Right, not just the patient. But being in home health, you chat on the phone between patients if you have friends that do the same thing. So you keep in touch, but the personal interaction is not there.
Yeah. Is that part of what you like about home health? Is the fact that you have some flexibility in your day? Your next patient isn't always there.
Yeah, the flexibility. Well, two things about home health. Yeah. The flexibility when your kids are small, like yours. When mine were small, my wife was home. She's a school teacher, but she was teaching our church. So it gave me the flexibility to go do whatever school activities. Yeah. So I was pretty involved for the first 5 or 6 years of school for my kids.
Yeah, very cool.
Then it turned into my wife went back to teaching, and then life took over and had to get back into working more. And but home health was at that time, really good for giving you the space to do that. Now it's, they make you have a pretty regimented schedule.
Yeah, and it's funny you say that right then too, because we were just talking about this. You've always been known as kind of a workhorse, that you can carry a heavy schedule, but also knowing that you're a very sought after, very liked therapist by your patients. And I mean, that's something, your story gets around with that. And even to further that, I get very protective over my own patients. Mm-hmm. So when a patient's on my schedule, I don't like seeing them go to somebody else. Mm-hmm. Sometimes we even have to convince them that they are going to have to get reassessed by a PT, and they don't even like the thought of that sometimes. You've been one of those people in the past that if I knew you were following in on a patient that I had been working with, I tend to kind of back off a little bit because I know at least the things I heavily value and know that patient needs, you still somehow provide, right? And I say somehow just to say, how do you carry the caseload that you do, but still maintain that quality?
Yeah, that can be difficult because, it turns into the company will provide whatever patients for you, and you try to schedule them and you try to do their location and make it an even flow. The hard part is when you get into a patient's house and they have a problem. So if it's an orthopedic patient, they're having a lot of swelling or drainage, or it may be infected, and you're looking at it, well, it's not a 30, 45-minute visit. It turns into a couple hours maybe.
Yeah.
So managing the schedule is very tough, and the distance you drive is very tough.
Yeah, and you carry a long distance too, along with that caseload. But how do you find time to do the documentation side of it? How do you?
Well, some of it, I put the vitals in. I'll put some of the main things in the note while I'm there. Typically, once I'm done, I go out to the car and I start talking to my tablet, try to get it on the tablet as much as I can, and it's fairly generic.
Yeah.
It takes a while to type up, so I don't type. I'm not a good typer, so I talk to it, and I do the best I can. But I get the primary things that say if a doctor's looking at it, or a PT or a nurse, whatever. They see if it's ortho that I looked at the wound, I looked at the incision, or the staple's intact, is it red, how's the bruising, how's the swelling, how's the pain control, any signs of DVT, the basic stuff you look at.
Yeah.
Then you start documenting, your exercise, your walking, and how they tolerated that, how many reps, range of motion. It kind of flows over time. But when something out of the ordinary happens, that changes things, because the computer, I think, gets used to what you're routinely telling it.
Yeah.
If you tell it something outside, it may really scramble those words. So you got to be careful if it's outside the routine to really.
Yeah. So you've kind of developed like a sequence.
Yeah.
You develop a system that works for getting that stuff done. The cool thing, and the thing that kind of sticks out to me with that too, is there's a lot of patients that tell us, so-and-so's face was in the tablet the whole time, or so-and-so was just typing on their thing. With you saying you tend to put like the high points and the things that pain level and vital signs, and then you dictating in the car, that still gives you time for what?
You're there for the treatment.
Yeah.
So, the companies will always tell you, oh, you should document in the house. You try it.
Yeah, absolutely.
You go in the house and you peck at a computer and ignore the patient, or talk to them, and you're kind of carrying them on while you're doing the pecking at the computer. It doesn't fly. Most of them are going to get mad. Yeah. So if you hit the high points, you take the blood pressure, I'll forget it. So I put it in the computer, I get the gist of it done, do the treatment, and then I'll come in, have them sign it, and be done with it. Yeah. And then get out in the car and finish it.
I like that. I think that's really good. And I think the like you said, they're going to notice it, and some do get irritated, but whether they get irritated or not, they still notice.
Right. Yeah, and you're really there because their doctor said they need therapy for whatever reason. Yeah. And most of them are resistant anyway, because you're going in their house and they don't like it. So you're trying to respect their house, their customs, their way of doing things. And if you're ignoring them, it doesn't work.
Yeah.
They'll call you on it, and so it's better to get the bulk you need done outside of the house and get the things you have to do in the house done quick.
I like that. And you've been in this a long time, so you've seen, changes in documentation systems and how companies, what companies want and what they're looking for. What have you seen over, coming on 30 years? Mm-hmm. So what have you seen change? I don't want to say good, bad, and ugly, but what have you noticed the most?
Well, it used to be you're writing notes on a piece of paper.
Yeah, big change.
And being done pretty quick. So some of the advancements from that to what we do now is good, because my handwriting is pitiful. Mm-hmm. So you're capturing these different systems capture reimbursements.
Oh, cool.
So a lot of the companies are wanting to make sure you're getting the pain notification done, meds, their homebound status, the things that make them homebound and ready to do what we need to do.
Yeah.
But the things that have changed over the 30 years or more, the specific things that Medicare may be looking for reimbursement. Okay. So it takes a little time. Every company's doing it. and some of them are more advanced than others on what they want you to put in.
Yeah.
Lately, it's put in, make sure you put the date that you're there, written out, why you're there, capture the admitting diagnosis, and some of the comorbidities too, because we don't only treat the admitting diagnosis. There's other things, whether it be diabetic neuropathies or whatever that go along with say balance, and so you're capturing a lot of stuff. So the changes have been putting in specifics to what you're doing and why you're there, and ultimately for the company it turns into reimbursement. You're still doing the stuff that you're supposed to do with the patient, and you're trying to capture all the stuff the company's looking for.
I like that.
And it can be challenging.
I like that, and reimbursement makes a lot of sense. I mean, that's how we maintain our profession.
Yeah.
So it does matter, definitely, and how that's evolved and what they're looking for.
Right.
They're looking for keywords, or they're looking. The big word in physical therapy is function.
Yeah.
Right. What are we assisting them skill wise, in developing them being more functional at whatever,
Right.
or more independent in their home, specifically for home health, and that you touched on point two with comorbidities. It's interesting. That's something I talk about. I swear probably on a weekly basis with my patients, that when we're in school, we're taught how to treat a Parkinson's patient, or we're taught how to treat a total knee replacement. But when you get into the real world, and it's fantastic your start, with acute care style, and my start was in the hospital setting, and I feel thankful for that too, because you get crash coursed into, now this isn't a knee replacement, this isn't a diabetic, this is a patient that had a knee replacement that's been a diabetic for 10 years and they're uncontrolled, and they also have this, and this.
Right.
And so kind of trying to find a way to not just prioritize what we think is going to be the biggest thing that we need to focus on there, but what are you struggling with?
Right.
And do you find that you have to lead your patients, or do you feel like they tend to kind of let you know right away what they're dealing with?
It depends on the patient.
Yeah.
Some are going to be, forthright with you, and some of them it's almost like verbal diarrhea. They come on, they want to tell somebody.
Yeah.
Some of them you really have to drag it out.
Yeah.
The ones that are the tougher cases, or usually the most resistant people, are the ones that have the things you really need to work on and find out what it is. And once you establish a personal connection with them, they bring the guard down. They usually will tell you. Now, it may not be a knee replacement, Parkinson's, stroke, whatever it is. It could be something that feeds into that. An emotional part of having Parkinson's. When you go through a joint replacement, nobody tells you about the emotional roller coaster because of the pain meds, the lack of sleep, the pain, the lack of function. Your partner's snoring over here and you're wide awake in the middle of the night.
So you sleep in 2 hours.
Yeah, exactly. So nobody tells you that stuff. So as a therapist, if we go in and we talk to them and we keep them, realistic to what they're doing, your knee or your hip, shoulder, whatever it is looking good. That's progressing fine. Your pain's under control somewhat. You're taking the pills, or you're constipated, or is everything working? Your bodily function is working. And then you get into the emotional part, sleep deprivation, emotional roller coasters. Some people may be predisposition to anxieties and things like that, and they start spinning it.
And more recently than ever,
Yeah.
that's coming to the forefront, I think, on the mental blocks of our patients, to where, in my head, the filter catches it, but are we screening patients for what they're dealing with on the mental side that's going to allow them to be successful with this surgery?
Yeah.
They go see a cardiologist, and they go do blood work and all this stuff, and they're cleared physically for the surgery, and then are they prepared, or are they able to hold that capacity after it's done? It's hard.
I would say, just put a number, 60% no.
Yeah.
Most of them, I think where this could stop and be changed and be made for the better is, say, an orthopedic surgeon. We got some really good ones in this area.
Absolutely.
Most of them don't discuss anything but, hey, we're going to replace your knee. This is kind of what it's going to be. 2 weeks, then you go to outpatient.
Yeah.
Home health outpatient. They don't tell you about the constipation, the pain, the things that go along with it that me and you will see, and the PTs see when they eval.
Yeah.
So our job in the home is, first assess the knee, whatever joint, make sure it's fine, and then start filling them in on, hey, this is what to expect. Most of the time you're going to have some constipation. Most of the time you need to be drinking plenty of fluids, walking. Here's your exercise program. Kind of go through it, try to stick with it.
Yeah.
But then you have to go into the things that nobody likes to talk about, which are the emotions. And, for instance, I had a lady today talking about her husband that died 4 months ago. So did the knee, made sure the knee was good, did everything, talk.
Yeah.
Let her get that out because she's in a vulnerable emotional state. Once that was over with, you could see she was very happy that we talked.
Yeah.
Probably very vulnerable.
Yeah.
I would be if my spouse passed. But that sets the standard. They're going to trust you. They understand what you're there for. They know that they can talk to you and you're going to do the best for them.
Yeah.
If they understand that, they'll comply with the therapy part, which nobody wants to do the therapy. I wouldn't want to do it either.
Yeah,
but they'll do it for you then. Because they know that you're there for their best interest.
Yeah.
And it's not a put on, it's a real communication between people.
I love that. And I think you're spot on with that because I think some people want to be business only, but I think there's, like I said, with mental, capacities and people that are just struggling in general, we're seeing that more and more. And I think with time constraints and efficiency and all of those big, fun things that we have to dodge a little bit of, I feel like they're used to not having that ear to listen.
Right.
And we, luckily, they're not coming to us in a clinic with 14 other people in the room.
Right.
We're in their home. Nobody's there. They've been isolated for this, for this surgery, and we walk in the door, and how important that is to open that door for the conversation to occur if it needs to.
Yeah.
And
let them know you're with them. And there's like most of my life I've had something. I teach people, don't do what I did. And I do it with my kids too. Don't do that. And thank God my kids turned out great.
Yeah.
But if you can empathize and understand, okay, this hurts, whatever they're going through.
Yeah.
It could be, we talked about offline, an autoimmune disease. I've had a hip replacement, got to get a knee. You can empathize with these people and they go, oh, okay, so he's one of us.
Yeah.
And he understands it. If people can relate to you on whatever level, they're more willing to do the therapy part that nobody really wants to do, and then they understand why. And they see you walking around or moving and doing things and, like you're normal, they understand, okay, this is short-term pain, and that's the way I can move around later.
Yeah.
They don't have to look as good as I do.
I love it. And it's funny, with a lot of therapists, when I was getting into this field, a lot of the other people that I met that were PTAs or PTs or anybody looking to be, come into the field, they've all had a bunch of injuries. That's always been like a common ground.
Right.
And I felt out of place because I hadn't been hurt very much. And when I got introduced to this field, it was just simply for some instability in my shoulder. And so I went to therapy for a short time, looked around the room and went, yeah, like I can do this. This is neat. And I'm 37 now and very aware of what it feels like getting out of bed some days. You're a little my senior now.
It gets worse.
How does that play into? It honestly has turned into maybe a strength for you to connect with people.
Yeah, it does. When you have I have Crohn's disease and I've got multiple joint arthritis. I was an athlete before and then at Florida State powerlifting.
Yeah.
So athletics has always been a big part. So when some of that's taken away with autoimmune, whether it be rheumatism, Crohn's, whatever, there's a bunch of them out there. Yeah. It can humble you, but it makes you, I guess it makes you be able to connect with a patient that's got whatever it is. It could be rheumatism, it could be other autoimmunes, because the underlying issue is not just that, whether it be your bowels or your joints, it's the fatigue. And most of them, I tell them, I was like, look, I understand that you're wore out and I understand you're tired. And it's not like you just ran a mile and you're tired and you recovered. Yeah. It's more that somebody turned your palate light down. So your palate light, your energy light is not near as bright as it was. You're functioning, you're doing your thing, but you're not, you don't have the energy to go do stuff that you had before.
Yeah.
And when you can relate to that, it's a big deal. But it's kind of a motivator too, because when you have things that are miserable in your own life and you're out helping other people, it takes away that misery.
Yeah.
So you can help somebody and it makes you feel better.
And kind of humbling at the same time.
Yeah, it's humbling, but I've never let the Crohn's or the joint replacements or whatever get me down long term. It's more the day to day, get out of the car, you take a few steps, like, oh, it hurts, and then you feel better.
Yeah.
So those things never stop me, but they are something that helps me connect and also makes it, I guess, more real.
Yeah.
They'll see your therapist getting out of the car and he's talking about, I hurt
limping in.
Yeah, limping in there, maybe using a crutch. I don't do that. But it's more, if they see that you're vulnerable just like them, you're connected.
Yeah.
Most people on a human level want to connect to somebody.
Yeah.
And when you're vulnerable in a patient spot, having somebody that can connect, legitimately connect to you. You don't have to be hurt to connect to somebody. You lend an ear.
Yeah.
You lend an ear. They're like, okay, well, John's really wanting to listen to me. He's trying to help. He may not have the same pains, but he understands that I do, and he's here to help. And that connection goes a long way.
Yeah, and I think it's so valuable, right? And I feel like it's one of those things that, like you're driven by that purpose, you're driven by that pull because it's outside of you. I've always heard like if you want to get some perspective on what you're going through, go help somebody else.
Right.
And that's been something that we've been, that's our career is embodied by that. And I think there's a lot of value in that. On that note, even we open that door for other people, but I find myself sharing a little bit within that too. That, like you said, you're relating in that place, but just those people that are harder to crack, if that makes sense, right? I know you know what that means. Then you offering a vulnerability of your own up, even if they're not aware of it, allows them to kind of let that guard down more. Yeah. And then when we do exercise or we walk, it's like the walking and that is secondary to the connection that we've made.
Right.
And that's always been something I leaned on for a lead in, and I think you feel similar to that.
You make a connection, when you're in a home for exercise, none of them want to do it.
Yeah.
So the art of distraction, it's an art, but it's also something. I'm open book. I'll talk to you about anything.
Yeah.
We'll talk about their kids. I'll see pictures on the wall. While you're doing your exercise, I'll ask them questions. Where you're from, what y'all do for a living. If you know what they did for a living, you kind of know how their temperaments are and their abilities to do things. They may be engineers that are really analytical about everything, step by step. You treat them that way.
Yeah.
If there's somebody who was, let's say a secretary that was, her fingers hurt because she's doing stuff, or she was up on her feet all day, or a barber or a hairdresser, whatever, their feet are going to hurt, their hands are going to hurt, their backs hurt. But you talk to them about that stuff, and it brings them out. And not talk to them about it. I'm an open book dude. I'll talk about anything. I don't care. I'm vulnerable in things, and some things I'm not.
Yeah, and I guess you could even say it allows you to speak their language.
Yes.
We're teaching it in the terms that they're going to be able to visualize or hear. It's as simple as somebody learning by seeing something, see you do it, or see it written down. I have a ton of patients that ask for home exercise program. Give me a sheet of all the exercises, or send me videos, and I'm really notorious for never giving anything out, because then that paper sits on the counter, and does that mean they're doing their stuff, or they have an understanding of the exercises? Not necessarily. Sometimes it just means that they have something and say, oh yeah, this is what I'm doing, versus me walking in to a visit and saying, hey, show me what you've been working on. And then you find out where the misses are. Right.
And a lot of times you go in and somebody has, you have a desire to have them do this regimen of, the basic generic exercise.
Yeah.
And it's too much for them. You have to break it down. Okay, let's walk. Let's just, for a hip, let's just keep it simple. Let's walk today. We'll do that. And then I'll show you some exercises later. So if you're walking, you're moving. If you're moving, you're pumping blood.
Yeah.
And you reduce the risk of blood clots. You also help the muscles. You get them outside. Sunshine does wonderful.
Absolutely.
Yeah, and you start looking at the whole person and not the hip.
Yeah.
It used to be when I was younger, when I was your age, it was like, man, you got a hip. I don't care about you, but you got a hip. We're going to work that hip.
Yeah.
But now it's really, there's a person behind the hip. You're trying to get that person to make the hip better.
Yeah.
But a lot of times it's just the simplicity of it works.
Yeah.
Not the PT set the agenda, the goal. That's the way, that's what they're there for. But they leave it to us, if they trust you, to figure out how to get to that goal. And you can start baby steps or you can go full in, depends on what the person's ready for.
And sometimes helping them navigate what speed to put it on and what you see in response. That's a big statement I use all the time is listen to your body, not your ego, right?
Exactly. Yeah.
It's not where you think you should be at or what are you comparing to.
Right.
A lot of people really don't have a tool comparison. They end up, they'll look online and we know what rabbit hole that goes. It can be good, but it can also be terrible.
Good to dead.
Yeah.
That's the internet.
When I think, have you seen a change in access to information?
Yeah, and some of the problem with that is if you're a layperson that doesn't understand. Most people understand some form of exercise. They played high school sports or they played kids sports or whatever. They get it. But when you're dealing with a disease process or a joint and all the other comorbidities, well, sometimes you don't want to push it. If you have CHF or COPD, you can't push it like you did when you're young. So you have to take those into account and let them know. Like you said, listen to your body. If you're tired, rest. Do it multiple times a day in small bouts, not one big session.
Yeah.
Split this up. Listen to your body on pain, because pain is real, and pain will stop you from doing it the next time.
Yeah.
So if you keep the pain at a minimum, you're keeping the inflammation at a minimum, and you're keeping the motivation a little bit higher.
I like that. And then you have the opportunity to be consistent.
Yeah.
Right? Is that where consistency is born and not, doing too much on look what I did on Monday and then I skipped Tuesday, Wednesday, Thursday, Friday. Right? So, developing some of those habits. And it is hard because we're very aware and you're very aware by trial by fire that when things aren't going right, how hard that is to kind of break through some of that stuff, or just the acknowledgement that you need to back off.
Yeah.
And that's okay.
Yeah, there's no harm in doing less.
Yeah.
There's harm in doing too much. And it's psychological harm and there's also physical harm. That our job is, when the PT goes in, does their eval and sets the standard for what we're doing, we try to figure out the best way to do it, and that changes all the time. Plus, we're there way more often, so we have to be nicer. We can't be quite as,
blunt.
Yes, blunt. That's the word. Yes, good word. I was thinking a few of them. But we don't have to be, we don't have to really test their limits every time.
Yeah.
We're there to slowly get them better. And then in home health, then usually to hand them over to outpatient for continued strengthening and whatever they're going to do.
Yeah, which could be a big shock.
Yeah, and I prepare them for that. I'm like, look, we're going through the physical part's fairly easy. We're trying to get you through the wound care part. We're trying to get you through healing, adapting to the new joint function, and then we're going to turn you over to outpatient, and they're going to start working the strength. It's not the same pain. It's muscle pain now, so it's a little bit easier to deal with.
Yeah.
If you know about it, but if you're thrown into the wolves, it's tough for them.
Yeah, and so recently I ran into you in a nursing home setting, and you had a phone call that your daughter was accepted to nursing school. So congratulations on that. That's super cool.
Yeah.
What would, coming from your background in healthcare and her just entering into that game, into that realm, what have you had advice for her, or do you have advice for her? What would that be?
Yeah, at this point, I'm telling her, the school part's separate. I keep it we'll break it into segments.
Yeah.
The school part can be tough. Pharmacology, those things can be tough. Stick to it, get through it. When you get into the working world, find somewhere where you're happy. She thinks she wants to do neonatal now. Maybe she does, maybe she won't. But learn what you got to learn in school.
Yeah.
Go to different, you started at the hospital, I started at hospital subacutes. You learn and you see a lot. Get that wide berth of knowledge, working there a couple of years. And then you have to evaluate whether nursing is really going to be it for you, because these companies will use and abuse nurses.
Absolutely.
And it's sickening, because I've worked with so many good nurses in 35 years that they're there and then they get so overwhelmed with what they got to do that they quit. Some of them go do related nursing jobs or they get totally out.
Yeah.
And when you have somebody that has a skill set and a personality that goes along with that skill set, and you abuse them so bad that they want to run from it, it's very irritating.
Yeah.
It shouldn't happen.
Yeah, and so I guess we're talking about burnout, right? So burnout, and it's a 4-letter word in our realm, just because it's so prevalent, and we've all felt it in some capacity. So how I guess with her going into school and then going into the industry, how have you been able to prevent burnout, or have you? I mean, we've had side conversations about this where we're fed up in ways.
I get burned out.
Yeah.
The things that make me happy, or when I go to, it may be one patient a day or a couple a week, whatever, that you go in there and you feel like you did something other than outside of just therapy. You did something for them, so that rejuvenates you. Yeah. If you can teach them, and most of it's really teaching. It's not so much doing; it's teaching, or talking to the lady who lost her husband, and you feel like, okay, you made a gains with her because now she may have got that off her shoulders. That helps minimize the burnout. The day-to-day grind of doing home health, whether you're a PT nurse, PTA, whatever, it doesn't matter. Your schedule's so fast if your company's busy that you're just doing one after another. And when you start losing sight of the individual and you're looking at your tab and going, oh, I got 7 more to see, that's not good. Because now you're starting to get to basically your Peter principle where you're not effective.
Yeah.
And if you're not effective, what are you doing?
Yeah.
And we've all gone into homes and we're like, oh, that was kind of a bust. That wasn't very good. I feel bad about it, but I gotta go next.
Yeah, and it doesn't stop.
No, it doesn't.
The ball keeps rolling. So when you get to that point, that burnout point, what do you do? Do you have any rituals or anything that you do to kind of hard reset to get back into it within a day? Or
no, it takes a little while. And with burnout, it's real. And I'd say I've been burnt out for 20 years because of the pace. Yeah. But it's those 1 or 2 people I see, or however many, that rejuvenate me, make me feel better. The burnout, something's going to have to be addressed with all the companies, no matter who they are.
Agreed.
They look at PTAs and, oh, you got a 2-year degree, that's all you are. No, you're really the voice of your company in there. And if you're doing it in a hurried job to get to the next because you've been assigned so many people, you're doing the patient no service, yourself, or the company.
Yeah.
So something's got to slow down where we still get paid well. We got to make a living. I'm not doing this for free.
Absolutely.
I'll help you on the side for free, but I got to make a living for my family.
Yeah.
So if you can have that to where it's a good company that understands that you have skilled people, no matter what position they're skilled. Your intake person's skilled.
Yeah.
They do a good job, and if they don't do it, we don't get paid.
Yeah.
So everybody has a part. And if it flows better and it's less restrictive on the person that's going out into the field and doing the stuff, it makes it so much easier. But you can't overload the schedule. Hey, you got to go 30 miles this way to see this person. You got to do it today. No, I'm not going to.
Yeah. Is that what you find that you end up having to do? Is just know your limits, your boundaries, or when you're starting to change?
Well, knowing and doing are 2 different things. Yeah, and knowing, I can't do that. I shouldn't do that. But then I feel bad about Joe Schmo that's out there in the middle of nowhere that I'm supposed to see. She's on here for a reason, and I feel bad about leaving them. So a lot of times in this field, we take the brunt of it, and we're like, okay, I'll do it. But it gets into our family time, our rest time, and that needs to stop because and it may rely on the person that's doing it, but really the company's trying to eke all they can out of you.
Yeah.
There's a few people that I've had as managers and owners that understand it and try to keep the morale up. And I've worked for tons of companies, and what you see is a start that's great. And then they get money focused. And when they get money focused, the whole periphery goes by the wayside.
Yeah, it's like it becomes robotic.
Yes.
There's and I've seen personally, my first job ever in home health, the lady I rode along with, I was blown away because I had never seen somebody connect with people so quick. Mm-hmm. Their guards came down immediately. She was kind of all over the place, and it actually played in her favor. I'm all over the place sometimes, so I can utilize that as an advantage. But I watched her at the end of our ride-alongs get a call from the company that she was being pulled for an interview to come into corporate. And I watched her change. I watched that in no better terms, erode the things that I admired personally about her, and saw what she could do in the clinic. And it's almost like people forget, right? And that's something I look for personally in some of the management, is that they do have some field time, not a lot of field time, because we know what that turns into sometimes, but just some field time so that they can keep the what the actual focus is.
Yeah, that one of the biggest shortcomings in every company, whether it be an outpatient company or whether it be a home health company or whatever. You know, the bigger companies, the subacute companies, they were owned by bigger groups. They had people, business people, that were professional management, that kind of stuff.
Yeah.
That worked pretty well. Everybody had their niche and did their thing. When you get into the home health companies, a lot of the outpatient companies, now you're dealing with a clinician that's been stepped up into a position, whether they're a PT or RN or OT speech, doesn't matter, or PTAs. We've done it several times. That doesn't mean they're good at it. You know, you can pull a clinician out of the field that's the best clinician in the field. Now you put them in charge of management and people and problems and growth and, you know, the books and all that stuff. And that's not my forte. I don't like it. No. I never did like it. I did it because I was trying to provide for a family. Then I realized, well, I'm not doing anybody any good. I'm going back out to the field and I'm happy.
Yeah.
So, but we get so many people that are connected to prestige, rank, and they're ineffective.
Yeah.
And it makes everything else worse for everybody else.
That's it. It's actually a big, strong, huge point. There's a guy I listened to, Simon Sinek, that he did a talk on that where he said he was specifically talking about burnout, I feel like, but he was saying that the erosion of the human element of healthcare is because number-oriented people are in charge of people that are caring people that don't care about the numbers, but they're leading them with the numbers. They're showing. I've sat in meetings before where we've sat as a group of professionals and recited our core values and recited things. And I was looking around. I mouthed the words because I was scared I was going to be one of the robots if I actually said it out loud. And this week we're down, 3% in our hospital readmissions, and they would go through all this and take the time away, I feel like, from discussing the things that we, in home health specifically, the amount of times that we're in a room with another clinician that works with that same patient is minimal. Yeah. That means we're not scheduling correctly if we run into another clinician, but in those capacities, that is our time to say, hey, what do you think about Mr. Jones? What do you think about Miss Karen? Whatever it may be, and to collaborate on that. And conference on those. I mean, they call it case conference, right? It's to conference on our people. And I see the writing start sometimes with, we're planning to discharge, or we're planning to reassess, recertify, and then the writing stops as we're telling the details.
Yeah, while you're doing that, I get they have to make the money, I get it, but when you have, bean counters telling you, okay, well, if you're seeing somebody for a stroke and you see them finally 10 visits, whatever it is, and they're making gains, but they want to discharge because it's not profitable. Is that ethical?
Yeah.
It's not ethical, man.
Or keep them when there's no skilled need, but we see that all the time. And I think the fight too comes with some of those topics. Is it the company? Is it insurance? Yeah. And I think insurance, I've always said insurance runs the world, and I've also backed that out by saying I don't know much about it. Yeah. And I kind of do like plausible deniability in a way, because if I were to give a lot of attention to that, I think I would run.
Yeah, the sad thing about insurance is, when you see around this area, if you have TRICARE or Medicare, you're going to get the best. Yeah. Because it's the best insurance. Yeah. If you have Medicaid or whatever, or a supplemental deal with Medicare, well, you're probably not. Mm-hmm. And it has nothing to do with us. We're wanting to get you better and do the best thing we can. And I get you got to make a profit, but you don't have to make it a profit at the expense of somebody's health.
True.
You can get them placed somewhere else if it's more appropriate for finances to get them in outpatient and they can do it, go to outpatient. If they can't get somewhere and you can see them and you can get them better, you can see them longer in the home, and yeah, you're going to eat a little bit of money. I had a guy that I worked for. You're familiar with the guy, and his philosophy was do what's right for the patient.
Yeah.
And he's 100% right. 2 bosses I've had over the years that did that. One was an OT, very good. She's moved off with her husband in the military. And the guy that you and I both know, do what's right for the patient. The profits will come.
Yeah.
You'll make money. You'll do but what's really better is you're doing something for that person that needs to be done.
Absolutely.
And that person will tell other people. The word of mouth gets around. These are small areas. There's a lot of people. They hear about us, and they'll say, "Okay, well, we'll try John. John sounds good. We're gonna work with John's company." And if you treat them bad, guess what? They're not going back to John.
Yeah.
They're going back to Lee.
And I think that's big. It's a big touch on as far as like growth. When these companies are trying to grow, there tends to be a disconnect between the marketing and sometimes I think there's some that can embody it pretty well, but there's a disconnect between the people that are pushing the growth and the people with the follow through to keep it, right? And that's something that I've fought and put a target on my back multiple times, because I say, what good are we doing this patient to bring them on if we can't take proper care of them? Yeah. If we're not able to reach them like we need to be able to reach them, or if every time we go to all the other 6 for that day that we're not present for those because we are so pushed, we are so busy with that.
Yeah, we get a bunch of them that if you get somebody on a caseload, doesn't matter the diagnosis. If you take the responsibility, the marketer does, to get them onto the caseload, you got a responsibility now. You said, okay, yeah, we'll take care of whatever ailment they got, and we'll take care of them until we discharge because they're better or going outpatient or somewhere else.
Yeah.
But when you get them on board and you're basically shorting them because you have back up a minute. When you're doing home health, especially, it's a team. It's not, just because you're a great PTA or a PT doesn't mean anything. If you have the nurses doing the nurse's job and you're collaborating with her or him, saying, hey, maybe there's a psych issue, get the psych nurse in. If there's a medical issue, blood pressure, whatever. Older people have a lot of things, dehydration, blood pressure, impactions, all that stuff. If you don't have the right balance in there, it doesn't work. Period.
Yeah.
And a lot of the companies try to do one side or the other, and inevitably, every one of them fails with that. They have to go back to a more balanced, because nurses serve a great job.
Absolutely.
We know some of their job, they know some of our job. And if you're smart enough to inform a nurse, hey, Mr. Smith's having a problem, they get an order, come in, they help with that problem. That patient's getting better and more confident because they got that part handled, and we can come in and do our part better.
Oh, I definitely agree with that, and that's where my head was just like pinging on is the idea that if the nurse has the medical side and the medication side handled and stable, it allows us to have the comfort to push when we need to push, or to notice when something's off.
Right.
Because if they're all over the place with uncontrolled diabetes, or their medication changes every day because they forgot to take this pill and I'll take it now, and all of that, then how do we notice a change that's out of character versus one we're expecting?
That's a big thing with PTA, because we didn't have pharmacology. We learned on the job.
It's one of my weakest points.
Yeah, I think for most PTAs, PT's pretty good at it. And that goes to when we see a problem in the home, we report to the PT, hey, such and such is having this and this. What do you think? But everybody in home health should have a little experience under their belt and can handle most situations. But our fallback is to go to PT and say, hey, such and such, they're having an issue with this. Do you have any suggestions, or just carry on what I'm doing? So we have that handled, but we're still in the home. And if you have the nurse come in, they can handle the medical side. Because you see people all the time that have boxes and boxes of pills.
Yeah.
No pill box, and they're like taking, I take this, I took 4 of these yesterday, and it's like, no.
Yeah, no.
Those are all diuretics, man. Don't do that, or whatever. That's a beta blocker, and you just took 4 of them.
Yeah.
Don't do that.
Or I don't take my diuretic because I don't want to get it, or I take my diuretic but I don't want to drink water,
Right.
Because then I'll be up all night.
Yeah, I don't want to. Then
we see it.
they dehydrate, they get UTIs, they get crazy, wiped out, go to the hospital.
Yeah.
And if Medicare wants to look at this,
Yeah.
Medicare,
Yeah.
be a little more informed about dehydration and these pills and the medications, and it saves you a lot of money.
Yeah.
And it helps us, and it helps the patient.
Love that.
It's just a reverse snowball.
Yeah.
So everybody, if they're doing their part, if you have good nursing, you have good PT, you have good speech, OT if they're in there, whatever their discipline is, if everybody's working together, and OT a lot of times pulls out because they may not be needed.
Yeah.
They'll do evals and yeah, I think we're good. They're
Functional,
doing it.
good.
Nursing may come in, well, it's just an ortho, he's doing fine, there's no signs of infection, we're out.
Yeah.
And then PT takes over, does fine. But if you ignore that stuff, playing catch up is hell.
Yeah.
You know? And the patient knows it, and
Yeah.
the doctor knows it. Then your reputation, yeah. So I'm in it for me, man. I want my reputation to be good.
Truth. Yeah.
While I'm helping somebody.
Yeah.
And I don't tolerate any of these companies putting me on the spot with ruining my reputation when I know I'm working hard.
Yeah.
And they'll do it. A lot of them will do it in a heartbeat.
Yeah, they absolutely will. And I think that's something that, you know, both you and I have worked at multiple of the same companies or somewhat been in cahoots. I did contracting for a long time, so there's a lot of the same, you know, companies around the area and there are a lot of similarities in them. I still struggle personally with how much pushback to give versus how much you just kind of like put your head down and work.
Well, that's the balance.
Yeah.
We have to meet. You have children, I have children. I'm going through college, so I got to pay for college. But you know, you don't want to push back to lose your job.
Yeah.
Because most of the people that you work with, whatever they're doing, they're all in the same boat. They're trying. There's a few of them out there that are just totally money hungry, but not many. Most are trying to do a good job. They maybe get singularly focused on what they're doing, and they forgot.
Yeah.
So you talk to them. So there's no problem with raising it. If they fired you for raising a legit issue, whatever. Move on.
You
Move
needed
on.
to. You need to move.
Yeah, and they can waller in their filth. I don't really care.
Yeah.
My job is to take care of the patient.
Yeah.
And if I'm doing the right thing, it works out.
So that's something big that checks your box, right? So when we talk about like reimbursement and patient satisfaction kind of plays into that some, but what other things are imperative in a visit or in your week boxes that you need checked?
Well, making sure that when I go to somebody's house, I'm at least trying to do what I'm supposed to do.
Yeah.
Some people are totally resistant. You can't break them. It doesn't really matter. You try.
Yeah.
So when I leave that house, I'll say, did I give the right effort?
Yeah.
If I did, great. There's times where obviously I've not done what I should have done, and I get a conscience about it. I feel bad. So checking the box, doing what I'm supposed to do. Also making sure they're getting what they're supposed to get. If they're in there and they're expecting therapy, you know, to do things, let's try to do it. Also, the collaboration between all the disciplines in there.
Yeah.
If I can do my part, then the nurse can do his or her part, the PT can, the speech, and get this patient, you know, better.
Yeah.
But if people just look at it as a Parkinson's patient or a knee patient or whatever, you're selling it short because that's a person connected to the Parkinson's.
Yeah.
And holy smokes, when you get into those things and you're dealing with somebody who's been I got people around here, Army Ranger, this has got Parkinson's now. It's tough people, man. They got tough minds. They're strong. They're robust people that need help.
Yeah.
And they're not asking.
Yeah.
And you have to go in there and help them without letting them know that we know you need help.
And the ones that are very mentally sharp, the common thing that I see is they're very mentally aware that they're declining.
Yes.
And that's a scramble. That's
scary.
and we see that and yeah, I agree with that entirely.
It's very scary. You know, I've treated, God, that's what great thing about my career is I treated people that were Iwo Jima, Pearl Harbor, that flew airplanes, you know, during the war, and all sorts of people from there to now to this war.
Yeah.
And most of these people are robust guys and girls.
Yeah.
They're tough. And they've been through a lot. I didn't go to war when I was in the military, so I can't relate to that. But I can relate to the aspect of being in the military, and you got that connection. And you let them know, hey, I get it, dude, or whoever. This issue is big for you. I'm going to try to help. I can't totally relate with it, but I'm here. You can talk.
Yeah.
And just let them know they're a person, because
Yeah.
those vulnerabilities of not being king of the mountain, and you're still trying to be king of the mountain, and you know you can't, that's a big mental hit to most folks,
Yeah,
whether
I
you're
agree.
military or not.
Well, and that's something that we talked about before we started recording too, is the idea that some people, not everybody's going to respond the same or walk through the door when we open, but maybe that our purpose is to keep the door open, so those people can go to those vulnerable places and they don't have to put on an act that they're doing fine and then they're miserable 5 days a week when we're not there. I think there's purpose in that, and I think
and they're sitting around their house and they're kind of waiting on you. And how many times have you walked into a house and you start talking to somebody and they literally tell you they want to shoot themselves? I've had it many times.
Absolutely.
Then you decipher, okay, well, I got to tell somebody. Obviously you tell somebody, but you start talking to them and you figure out they're lonely, they're hurt, the disease process has gotten the best of them, and nobody's explained to them what the disease process is. They're just seeing it on the internet, and it's doom and gloom on the internet.
Absolutely.
If you're there for somebody, they'll respond. And if they need more, we have psych, we have all sorts of people that come in and help that stuff. But you see it all the time with older people that are vulnerable and not feeling well, they're down, they've never been sick before, and all of a sudden, bam, they're hit with something, and hit with something pretty significant. Somebody's got to be there. And it'll be me.
I like that. And so in that capacity, if neither of us want to be in therapy forever. We have aspirations.
30 years later.
Well, it's funny because I kind of see like my future in you a little bit, because if I've been resisting heavily by locking fully in. I mean, I'm 12 years into my career, but I'm like still toe in the water, even though there's some successes in there and some things that I've really excelled at. If you were to leave the industry tomorrow, what would be your legacy message for physical therapy on like the close of a chapter? That's a big question, but what do you feel like you want to leave it with?
My reputation or what?
Maybe just like if you were to pass the baton to people coming out of school and entering this career, what's a message that you would want to see carried on in some way that you've seen being, successful at what you do, and what's so imperative in our field?
Listen to the person, connect to the person, treat the whole person. PTs, PTAs, whoever it is, has a great academic, background. That doesn't mean squat. When it gives you the fundamentals. When you get out in the field or get out in the clinic, whatever it is, if you understand that person and you can treat whatever ailment you're treating and also help that person, this is what it's really all about. And sometimes it's spiritual. A lot of times it's spiritual. Give them hope. You don't have to convert them. I'm not trying to convert people to Christianity, although I'd love for them to. But give them hope. Give people a purpose. Let them know you're there for them. And don't, when they call you, obviously in the middle of the night, don't answer probably, but if they call you and they need help, do what you can. Set them up with the right people. So these people that you're seeing, no matter what setting, no matter how irritating they can be, those more irritating people are usually the more vulnerable. Listen to them.
So hard exterior and cracking the shell to get to the person. I think it's like injecting the humanity back into what we do.
If you don't do it, if you look at this as just a job and you go there and you go home, it's not going to work. You got to have a caring heart. And from our perspective, when you have a caring heart, you also get some people taking advantage of it. So be it. I'd rather be taken advantage of and feel a little bit bad that I let them do it versus just stiff arming them and moving on. Because you never know how that one smile, that one word, that one interface with somebody can change their whole life.
I love that. And I think that's kind of the whole idea of why this podcast exists now, is because there's things that don't make it in the chart, that are not things that are well known unless you're in that interaction. And those are things that matter most to most people. And I think that's something that we can definitely pass to the next generations coming on to try to catch that baton and move forward.
There's some really talented people that I know that are going through PT school and just academically smart. And a few of them I know are already very compassionate folks. If you can tie those two together, you got to do your job. That's it's a job. But if you know that, do the job for that person, it's totally different. And it makes things a lot. And it makes you feel rewarded when you go home may not financially be rewarded, and you may be working your tail off, but if you help somebody that day, you feel it. And when you feel it, it gives you enough to go to the next day.
Yeah.
If I was to do something different, I don't know what
How do I check? Yeah. How do I? And I think that's been the holdback for both of us too. Is how do we get the flexibility, the income, and still get the impact? And
it'd be nice if, PTs can move up and do other things, and PTAs can too. You can move on. Nobody's, stuck. However, it's very difficult sometimes to break out of that. I got to make a living right now for my family.
Yeah.
And try so. I'd love to do something related in the field to help other people, but I haven't seen it yet. I've been searching for 30 years.
Yeah. I've started my search more recently, but still the same idea.
Yeah, I think the healthcare is changing. The big populace is coming up. The baby boomers are here.
Absolutely.
And we got to have a lot more nurses, PTs, but also capacity to deal with folks. And I don't know what's going to come, but there'll be a place for both of us doing something, whether it be this and we get rewarded and we're happy, or something else we get rewarded and happy.
I love that. I think it's a great point to end on. And I want to thank you. You were so receptive when I reached out to you, and we've had some good chats along the way of similar ideas of what do we move into. Right. And I just want to say thank you for trusting me and coming on and having a chat.
I appreciate it.
Fantastic, man.
Keep
thank
on
you
doing
so
it.
much. We'll close it out there.
Thank you.
Thank you.